Welcome to another episode of the Everyday Expertise Podcast. I'm your host, Roland Martin, and I hope that today's conversation will expand your knowledge. Before getting into this week's episode, I want to remind you again about the question and answer segment that we are planning for episode 15. I'm going to invite my brother, Ricky, back to the show, and we are inviting you, the audience, to send us questions that we will read and answer on episode 15. We are planning to record that episode on September 29th. I will leave it at that for now, and we'll provide more details at the end of this episode. Today, I'm excited to welcome Richard Bean to the show. Richard is an optometrist who practices here in Ontario. He is also a good friend and mentor to me, and I always enjoy chatting with him and hearing his perspective on life. He obviously knows a lot about how the eyes work, how to care for our eyesight, and gives a perspective on what an optometrist is thinking. I hope that you will enjoy it and learn from his expertise. Welcome, Richard, to Everyday Expertise. It's really good to have you here.
Thank you, Roland. It's an honor to be here. I don't think I told you this before, but I really don't listen to podcasts until Everyday Expertise came online, and I'm a faithful listener now, so I'm honored to be here.
Wow, so have you picked up other podcasts because of that, or is it
I haven't.
Okay,
I found, I initially, my first reaction to your podcast is, wow, who has the time to listen this long? But I found out that it works perfectly into my week's run.
Okay, so you break it up throughout the week,
Yeah, so into 3 or 4 runs, so it works out well.
That's great. Yeah, no, running's a fantastic way to listen to podcasts, so that's great. Yeah, no, I'm looking forward to hearing about your work in optometry and learning a few things from you. So tell me a little bit, what does your work look like currently?
So I think the focus here tonight is primarily optometry, and you're going to have to ignore some puns. They're largely unintentional, like focusing on optometry. So yes, I am a private practice optometrist, and so that is what I do 4 days of the week. So
you're seeing patients that come in, or what do you mean by private practice?
So yes, as opposed to being in a research setting or a hospital setting, or teaching. Private practice in New Hamburg, Dolman Eye Care Center is the practice where I've been at for the last dozen years. And so my day is filled with routine and emergency care of eye care. Mm-hmm.
So people will come in with emergencies, or will you have to respond to things outside of normal hours as well?
No. So our clinic is we simply take care of emergencies within our operating hours. Outside of those hours, we'll be referring them to emergency.
Oh, okay. Is there like an emergency eye center, or do they just go to the emergency room?
Yeah, St. Mary's Hospital in this region is where the emergency eye care is taken care of. So that's where we usually send them to, and there's an on-call ophthalmologist there who will take care of them.
Yep. So are you having to book your patients and that kind of thing?
So when I show up in a given day, my day is usually filled with patients who have been slotted in. So who have scheduled their appointments or have been in a recall where we have recalled them back to the office for an annual or biannual appointment. And so I show up, and I'm going to have between 12 to 20 patients that are scheduled for me to see that day in time slots. And then, so that might be routine care, or that might have been emergency care as well that they got. They called in that morning with a concern and got booked in.
So do you try to keep a few gaps in that case that happens?
That's the ideal. More often than not, especially pre-COVID, we're trying not to limit this somewhat in COVID, is they just get slotted into the day, and we'll just work them into the schedule as we have time.
Okay, yeah. Have the appointment times gotten a little shorter with COVID, or not?
So we're trying to keep the patients in the office as for a short time as possible.
Okay, yeah,
to minimize their time in the office.
I was in for an appointment. It was a few months ago, but since COVID, it just felt like I was in and out of there way faster than it would have been.
Yeah, so that's
past.
intentional.
Okay.
We're also trying to limit the numbers of patients in the office. So my actual schedule is a little more relaxed than what it was pre-COVID. Just to try to limit.
They're not interacting more than they'd have to, or something like that.
Yeah, just keep patient numbers down in the office.
Yeah, no, we'll get back. We'll get into a little bit more some of the things that you do on a regular basis and why you do some of those things. But before we do, are there any other hobbies or interests that you have outside of your work that you'd like to share?
Sure. Yeah, so optometry takes a good chunk of my working week, but certainly I have lots of interests outside of optometry. I'm a husband and father to a beautiful wife and 4 young children, and so I absolutely love spending time with them.
Nice.
I love travel, outdoor activities. I'm a bit of a foodie, either eating and also cooking. So you combine family, travel, food, outdoor activities, and I'm in my happy place.
Nice.
Then. So whether that's hiking or biking, things like that.
Good. Yeah. What's been a favorite trip that you've done in the last couple of years?
Oh, well, one that comes to mind, just maybe a favorite hiking, was Northern Ireland. We were over there with my parents-in-law.
Okay.
And this was probably one of my favorite hikes. Hiking up, it's called Slieve League, and it is. So you may have heard of the Cliffs of Moher before, which are famous cliffs in Ireland. These cliffs are about 3 times that height.
Oh wow!
Way off the sort of the beaten trail of the tourists, and just some fabulous hiking there.
Oh, nice.
So that's one that comes to mind right now.
Very nice. Yeah, no, love to visit there sometime. So sounds great.
Yeah. So other interest. Father and husband, also a pastor. So that is that's really where a lot of my passion goes.
Okay.
I would say. Certainly I care a lot about my patients as well, but outside of work hours, a lot of my energy would be devoted more towards the church and some parachurch organizations as well that I'm involved in, their board work and things like that.
Yeah, very good. And so you said you just work 4 days a week in the clinic?
Yes.
Does that allow you time to focus on some of your time in church?
That's
work
intentional.
And that kind of thing?
Just to give me place to invest well in my family, but also in other responsibilities outside of work. So I cut back to 4 days after my ordination there 10 years ago.
Yeah. So there would be work for you to do 5 days a week if you wanted to.
Yeah. This is my choice.
Okay. Yeah, very good. And we might find out some more about you as we talk about what led you into optometry, or how you chose to become an optometrist, what led you into that. So let's talk about that a little bit. Was that something that you, as a young child, you had a dream to be an eye doctor, or where did that kind of start?
Yeah, I would have never seen... So we used to visit the optometrist on an annual basis, which is a good idea. And so I do have memories of coming home from some of those appointments and playing eye doctor with my sisters.
Okay.
Where we'd set up the E and we'd have an occluder and cover the eyes. And so I do have those memories, but never to the place where it entered into dreaming that I would do that someday.
Okay.
So yeah, that never really entered into my game plan until actually my second year of university. Is where I started thinking seriously about optometry.
Had you thought about healthcare at all before that, or?
Yeah.
Okay.
So I don't know if you want some of the steps that led me here.
Oh, I'd love to hear some of whatever you want to share.
I mean, there's a short version, which it would really be, God opened doors and I walked through them.
Right.
But the longer version, growing up, grade school, I would have been much more interested in thinking I was going to be a carpenter, rough carpentry. That was just, I have no idea why I was interested in that, but that's where I thought I'd land. After grade 10, I wouldn't say I excelled in math and science at Fairhaven, which is great education, but just wouldn't have said it just gave me a fabulous grounding there in science and maths. Yep. So I would have thought if I'm going to do more schooling, it's going to be more into the humanities or something like that. Took 2 years off, worked at Shervin. So I know Kevin was on here. Yeah. And so it was interesting listening to his talking, because I would have started back when they were still back in Wellesley, when it was a very small, 12 of us, or 13 maybe when I started.
Oh, wow.
So I started there when I was 16 or so. And worked there, which clarified a few things in my mind. One of them was that I did feel like I wanted some further schooling at that point in time. So I worked there for 2 years. Great experience. But then went back to high school and went to Huron Park in Woodstock. And that was really a game changer. Had a fabulous math teacher, grade 11 math teacher, who really opened my eyes to, or just really piqued my interest in mathematics, which then, but also really gave me push me to push myself, I guess, into further schooling. And so that was a year of really opening. I hit a lot of the sciences in that year and math. And at the end of that year, applied into college at that point.
Okay. Did you do both years of 11 and 12
so I
in 1 year?
fast-tracked and 11 and 12. I picked up some credits while I was working at Shervin. And so, it was a heavy year that year. I did, it was a semester, so I did grade 11 math the first semester, grade 12 math second. So it was a heavy year, and applied into nursing, which wasn't really what I was after. Paramedic was really what I was after at that point in time. And got accepted in. I also applied into, because you could apply, I think, for 5 courses. I applied into computer program. Like, can you imagine me computer programming? I have no idea what I was thinking there.
I think I probably can, actually.
Oh, well, no, I can. So it was healthcare that I was interested in, paramedic. But my high school teachers talked me out of it, basically. Paramedic.
Out of being a paramedic?
Yeah. Okay. I think they saw more of maybe where I was oriented in life, and said, "Are you really sure you want to do shift work for a good part of your life until you can work up seniority where you're out of shift work?" That was a good call. I would have loved it, but especially looking at some of the other interests I have in life, it would have been a challenge.
Right.
So anyway, I came back into my OEC year.
Okay.
Which is when grade 13 was still a thing here in Ontario. Okay. And again, really hit the science and maths. And when I graduated, my high school teachers really urged me to think seriously about university at that point. Okay. And I was interested in high school teaching, or in medicine, or in research. And sort of my 2 favorite subjects were biology and chemistry in high school. And so so I applied to University of Waterloo, along with some other universities, for biochemistry. Okay. So that was what my undergrad started in
So you
Waterloo.
went right from OAC right into
Correct.
First year of university?
Correct. Yeah. And so really thinking probably medicine was where I was headed there, but thinking about teaching and research maybe as well. And it was just a few things along in that first year, first 2 years, I guess. Talking with people, really would recommend that for students to talk with people who are actually in the profession, whether is it a good fit for you or not. Yeah. It's one thing to read, off of websites that describe what the career is like. It's another thing to talk right to an individual.
Yeah.
And it was probably a bit of a low point for medicine here in Ontario with family doctors. And so didn't really pique my desire to go into medicine at that point in time. Overworked, underpaid was sort of their what I was hearing from them. And then after my first year of biochemistry, I worked in a research lab at Waterloo.
Okay.
In biochemistry, in nuclear magnetic resonance spectroscopy. And I could talk more about that. Good experience, but it really clarified in my mind that I wasn't cut out for research. Okay. I needed to interact with people.
Were you doing experiments or?
Yeah, I was.
Yeah.
I was basically growing some crystals that we were then going to be characterizing using spectroscopy.
Right.
That really stroked off research. And I know research, it wasn't necessarily a representation of research, but I worked alone a lot that summer, and I just said, no, I need to interact with people, and I need to see how I'm actually impacting people's lives. And I knew that research was going to impact, I felt, somewhere down the road, but it wasn't close enough to me, if you know what I'm saying.
Wouldn't have had the motivation maybe to do it, or that makes sense.
Yeah, and so it was at that time that I started looking at other career paths as well, besides those three.
Okay.
And one of the things that a lot of people don't realize is that the only English-speaking optometry school is in Waterloo. Okay. Is at the University of Waterloo. So
sorry, the only English
speaking. So there's one in Montreal.
So in Canada,
speaking.
this is
yes.
Okay.
Sorry. Yeah. Did I say Ontario? I meant Canada.
Well, I wasn't sure if you maybe did say it. Yeah.
So a lot of my colleagues came from BC, Alberta, PEI, etc.
Okay. Yeah.
And so here's this school that's sitting right in my backyard. It was at the school I'm attending there in my undergrad. Yeah. So the proximity to it, gave me some exposure to optometry. And also, at that point in time, I've been healthy majority of my life, and so my interaction with eye care was actually greater than with medicine, because I would have been going on an annual basis, got glasses, when I was in grade 6 or so. And so it was in second year, I believe, I started volunteering at my optometrist.
Oh, okay. Nice.
And so that was a great experience to really give me a sense whether this is for me or not.
Yeah. What were you doing there?
Filing, answering phone calls, things like that. Nothing significant, but just gave me an idea of what was happening in the practice.
Was that something they did regularly, or did they just
I asked.
offered? And
I asked. I don't really know if there's been many who have been. There's been some who have job shadowed since that time, but not necessarily volunteered. Okay. And really recommended in that it really. Felt like a significant point in my interview when I went to interview for optometry school that I had taken that step. Because really what they want when they admit students into optometry schools, they want to make sure people actually want that this is what they're after. They don't want to get people into the program and then find out that really, oh no, they actually wanted to do surgery, which I don't do. So they want to ensure that
what you're
students know what they're getting into. Yeah. So I volunteered. And then I worked there for a summer as well prior to optometry school.
Okay, like as a paid position?
Yeah.
Or? Okay.
Yeah, nice. Summer student. And so that really gave me a sense that, this is what I want to do. Mm-hmm. So that was what led up to me applying into the program.
Okay. So you decided a few years into undergrad that you were going to do it?
In my second year.
Okay. Yeah, that's when you decided to. So did you have to do some specific courses then?
Yeah, so I switched out of biochemistry then, because that biochemistry is a double major, so it gives little room for prerequisites outside of biology and chemistry.
Okay, yep.
And there were things like algebra I needed. I needed ethics, I think, psychology. Things that I didn't have enough elective space in biochemistry. So I switched into honor science at that point in time.
Gotcha.
So I did 3 years of honor science and then got accepted into optometry school.
Okay.
So
that would have been, you did 4 years of undergrad total?
So I didn't.
Oh, you didn't? Okay.
Even though I have an honors science degree.
Gotcha.
Waterloo has this funny little loophole that if you do 3 years of undergrad honors science, if you're in the honors science program and you do 3 years, you need 3 years to get into optometry school. Most students will get in after 4 years.
Okay.
After they have their degree. But Waterloo, I don't know why they do this, but if you have 3 years and you don't actually get your diploma or your degree, and then you do your 4 years of optometry school, and then they look back and say, oh, we think we'll give you an extra year for free here. And so they give you an honors science when you graduate with your Doctor of Optometry.
Well, they just do that for their own program?
They do.
They don't do it for any other school?
Not that I'm aware of.
Okay, interesting. Yeah,
so if you look at my degrees, they both are dated the same date that I have my Bachelor of Science and my Doctor of Optometry. I got them the same day. So
I see. Yeah.
It's a bit of a weird thing, but that's the path I went there. Yeah.
Okay. So is optometry school 4 years then?
It is.
Okay.
4 years. Correct.
So is that just focused on learning about the eye and how to take care of it?
It is.
Yeah.
I mean, and the eye is part of obviously a body, and so we have to learn much about systemic disease and anatomy, physiology. So that's a big part of, at least early on in the optometry program.
Okay.
And then it just continually narrows as you move through the program and focused on more the eye.
Yeah, and I might see if you have anything more to say about that a bit later on. I remember, I think it was while you were just starting an optometry school, I remember you saying something like that we're learning about all the diseases that you can identify from studying the eye or something like that. So it was a fascinating thing for me. Were there, did you have to, I don't know if co-op's the right word, but did you have to do optometry work while you were in school then too, or is that part of the training?
That's a good question. So by second year, we start practicing on each other. All right, so doing eye exams on my
just like a normal eye exam.
Correct.
Like I'd have if I go
in.
In.
So I mean, there's certain techniques that we'd be practicing on each other. So in the optometry school is you walk in the one clinic setting, and there are, I don't know, are there 30, 40, probably 45 different optometry lanes, so all set up like an optometry office. And so we'd spend hours there practicing on each other. And because most techniques you can do on each other,
right?
So we'd spend lots of hours in school hours, outside of school hours, practicing on each other. By third year is when you begin seeing patients under supervision in a clinic setting there at the School of Optometry. So there's a large public clinic there at UW where by third year, you're starting to do eye exams on the public with a supervisor who is watching carefully. And
like you're being directly supervised?
So it depends. Initially, in the first week or two, yes, you are. But then as time moves on, that supervisor will probably have 2 or 3 or 4 students that he or she's supervising and will transition around. And so that's third year. And then fourth year is split into 3 different parts. One part is spent at the school. So there are multiple sub-clinics at the University of Waterloo in the optometry school. So there's the primary care clinic. So that's your routine eye exams. But then there are also an ocular health clinic. So that just focuses on disease. There are binocular vision clinic. There's a pediatric clinic. There's a low vision clinic. There's a contact lens clinic. So we would in fourth year, then we would rotate through those different clinics, getting exposure there.
And these are like ones that the public comes to?
Correct. Yeah, exactly. So that is that's one segment of fourth year. Another segment was where we had to spend a clinical placement outside of Ontario. At that point in time, Ontario had limited. I'm trying to think here of the dates, but limited where we were limited in our prescribing of drugs here in Ontario. Our scope
Okay.
has since opened up, so
I
we
see.
can prescribe drugs at this point. So we had to spend time outside of Ontario. So I spent 3.5 months in Detroit, downtown Detroit at a veterans hospital.
Okay.
And where, I mean, this was an aging population that I was seeing, and pretty much every single patient had some disease, some eye
Okay,
disease.
I see.
So fabulous experience there of exposure to disease.
And that was to give you experience in prescribing things that you wouldn't have been able to hear?
Correct.
Okay.
Yeah.
I see.
So because as we graduated, we were graduating with the credentials to prescribe, but we needed experience in that.
Yeah, okay.
And so thankfully that's since changed here in Ontario. So I spent that time in Detroit. And then there was another third of the year where you could choose where you wanted to spend your practice hours.
Okay.
So I split that. That was when I spent 2 months or so in Africa, in Malawi, Africa.
So it's like anywhere in the world.
So I was one of the first to go to Malawi.
Okay.
But some would have gone to Asia, Hong Kong, U.S. Most would probably have stayed close to in Ontario.
So you could also do it like locally.
Right.
Oh, okay.
And so I split my time between Africa, a clinic in Cambridge, and Dolman Eye Care, which is where I was planning to end up when I graduated as well.
So a couple years ago, I was booking an appointment, and they wondered if I would be okay going with a student. And they said it'll be cheaper, and I said absolutely, I would be okay with that. So is that probably what you would have been doing?
So this was at the clinic where you
my regular clinic.
So that would have been a fourth year intern who was in that rotation.
That makes sense, because then she was part of the practice the next year when I went. So
So that is a great experience to get that hands-on experience, real life experience, because the clinic at the University of Waterloo is probably not real life. I mean, it's run in a large clinic setting, but you don't learn some of the practice management things that you're going to need to know when you're in private practice. So what's nice then is that when you graduate after fourth year, you're ready to practice.
Okay.
So you have to write licensing exams,
right.
but you're ready to go.
There's not like a time of like residency or
correct.
They would have medical.
So that's where the schooling hours is actually similar to medicine, but when a medical doctor graduates, then they have residency to complete after that, where our sort of equivalent of residency is included in that fourth year of optometry. You can go on and do a residency in optometry, and some students will do that and become sort of a specialist in whether it's contact lens or binocular vision therapy, things like that.
Okay.
But I didn't take that route.
Okay. Yep. So you were able to get a job then at your local clinic after that?
So I was there as a patient since I've been 5, and then volunteered, summer student, interned, and so it was just a natural progression there. That started there.
Oh, that's great. Have you seen changes then? So it's been over 10 years, right, since you've
12 years.
12 years, okay, Have you seen changes? You talked
in
about
the profession?
Or just in your job or things like that?
Yeah, so therapeutics, having the opportunity to prescribe was huge. It was such a pain prior to that, where I knew how to prescribe, but I had to send a note to the family doctor or to the GP saying, please prescribe this drug for this patient. So that was fabulous when our scope opened up to allow us to prescribe. That's been, I don't remember, probably 10 years ago.
So it was just a couple years into your practice.
Yeah, long enough for me to be really grateful when it came. So that was big for that. But it is a changing field technology-wise as far as diagnostics. We might talk about some of those diagnostics.
Like some of the technology that's available?
Some of the imaging that's available that is just, when I graduated, it was maybe in a retinal specialist office at, Ivy Eye Institute in London, where the retinal specialist would one of these instruments. Where now we have one in our office, and I use it on most patients.
I see.
And so in the past, where it'd be like, boy, I think this is what's going on. We're now, hey, let's just run an OCT. And yeah, that's exactly what we're dealing with there. So
you can get much quicker feedback by doing it yourself?
Right. So we're not having to refer patients
Yeah.
out near as much to get a second opinion or, to verify our diagnosis.
I don't know if you know the answer to this, but are there companies that have made that technology more accessible, or do you know what?
There've been lots of companies. I mean, this is a...
Yeah. But is it like inventions that have been coming, or is it just that this technology is now more available?
Continued inventions.
Okay.
Yeah.
So yeah.
Absolutely.
Yeah.
Lots that has been, lots that is in the pipe to come yet.
Okay.
As well.
Yeah, that they're developing.
Yeah. AI is a big one.
Okay. Yeah.
With eye care. One thing that you'll hear about my work is that I'm looking in lots of eyes in a day. And the key is to pick out what's abnormal. And that's some place where AI can actually be really good at by scanning thousands and thousands of eyes and picking out what's abnormal. It's not going to replace my work, but it may be adjunct to my work.
And maybe pick out things that or give you a set to look at further or something like that, where you can ignore more. Yeah.
It's not it's not impacting my work at this point, but that's in the future.
Do you think it'll ever get to the point where we can just take a picture of our eye with our phone and just send it to you, and then, or send it into something and then it gets kicked to you if there's an issue or something like that?
Yeah, I don't think it will replace routine eye exams.
Okay.
I think it will have opportunity for use, though, in developing countries.
Oh, yeah.
You'd be able to screen all kinds of patients there with a cell phone.
Okay. Wow.
Yeah.
Well, that could be really powerful then.
It will be.
Yeah.
It will be. And even for remote communities where there might not be eye care professionals, where there may be able to be images taken and sent. Teleoptometry is something where we'll probably see some growth in.
Yeah. Interesting. Is it overwhelming trying to keep up with a changing field like that, or do you just kind of...
You need to stay on top of it.
Okay, yeah.
You do. And we're forced to, as in to stay registered in Ontario.
Okay.
We need 70 hours of a continuing education every 3 years.
Okay.
So that idea would be to stay current on drugs, to stay current on technology, best practices, things like that. So
so it's kind of prescribed as part of the job.
Yeah, so that's just licensing that's required. But there's lots of journals that are available to stay up to date. And so that's what I do.
Okay.
I do a lot of reading outside of work hours.
Okay.
Or, if I have a cancellation, might pull out a journal and read.
I see. Yeah. Is that something you enjoy about the job, or does that feel like work?
It feels like work. Not difficult work though. I mean, I need to stay current.
Yeah.
Right?
Yeah, for sure.
One thing that I do miss currently. So didn't come up yet, but so I talked about the school clinic there of how students would be in there, and then there would be a supervisor there as well. So 6 months after I graduated, I was asked to come back in and supervise students.
Okay.
Yep. In the primary care clinic and the contact lens clinic were the two main clinics I supervise. So I did that for, I guess it's been about 2-3 years since I've stopped doing that. So upwards to 10 years of doing that. And that was really good for me because the students are the ones who are learning sort of the latest.
Right.
And had questions. And so they would be asking me the tough questions. Patients don't necessarily ask me about some of the cutting edge research where the students did. So that pushed me at that time, especially to stay current.
Okay.
And so now I'm not basically got too busy in private practice. And so I'm not at the school anymore. And I do miss that interaction with students because that's really healthy to have that as a practitioner to push you along.
Yeah. Did it feel like teaching what you were doing with that, or?
Yeah, so there was teaching components to it, but primarily it was supervising, but then taking the learning opportunities that came out of that patient encounter and talking about it afterwards. And so it wasn't nothing prepared, lecturing or anything like that. It was on the spot learning.
No, I just when you brought that up, I thought about that. You'd said you'd been interested in being a teacher maybe back in high school, so I didn't know if that was something you enjoyed with that or not.
It was something I enjoyed. I would really, for me to have continued there, I would have needed to go on and get a master's degree. Probably I was kind of at the upper end of my knowledge at times.
Right. Yeah.
And even I wouldn't be able to, I don't think they would hire me at this point. They would I don't know if their expectations have risen, but some of the I think you pretty much need a residency or master's at this point in time to move into the teaching there. And so I've given that some thought, but nothing serious. I think I have enough interests outside of optometry that are consuming my time at this point in time for me to pursue that further.
Yeah, interesting.
But, yeah.
All right. Well, you've been talking about some of the things that you do as part of the regular procedures when someone comes into the optometrist, and so I guess I was thinking about my own experience. So I do what you're supposed to, and I, like you said, I do my annual checkup or my appointment, mainly because my contacts run out. And, that reminds me that I need some more. So yeah, I guess I've been doing these tests for years, and or having these procedures done, and so a few questions about what they are, maybe more what the purpose is for them. So I don't know if you're able to explain it so that I can understand, but I think you'd probably do a pretty good job of that. So I guess at least the way my optometrist does it is we come in, and then usually not the optometrist, but someone
pre-tester.
Will like make me come up to a machine and look in, and there's usually like a picture of a house or something that I'm looking at. Does that sound familiar? Okay. So what's that?
So maybe I'll just walk you kind of through an eye exam.
Yeah, perfect.
Here, and try to explain what we're looking for in each step.
Yeah, that'd be great.
Yeah, so pre-testing is done by techs, trained techs to do what we call database testing. So this is just testing that's done on every patient that comes in. And so what you were referring to is an auto refractor or autokeratometer. So essentially what you're doing is you're looking in at our office. I think it's a barn, maybe.
Okay, maybe that's what it is. Yeah.
When I was a child, I remember it was a tractor.
Yeah, I remember it used to be a tractor too, and then suddenly it changed.
Then I think one of our other instruments, it's a hot air balloon. Okay. So what you're doing is you're looking in there, and what it's doing is it's taking an estimation of your prescription. Of your glasses prescription. So it is shining light in, and which bounces off the back of your eye. It's looking at the reflection that's coming back out and giving an estimation of your prescription, your glasses prescription. So, and it's also giving a measurement of the curvature of the front of the eye, which is something we care about in fitting contact lenses. So it's going to print out of there or send it to our computer what the auto refraction is. That's not your prescription yet, but it gives us an idea of what it might be, or gives us a starting point.
Like, is it so you say a starting point, does that mean that it's determining where you start the testing, or is it something to compare to once you do your own?
So I use it more as a starting point.
Okay. Yeah.
Yeah. So there's ways that we can do that manually as well in the eye exam, where you walk in, I have no idea what your prescription is, and by using a retinoscope, which doesn't get used routinely anymore, it would have at one time been done on all patients, where I look in usually about 66 centimeters away from the patient. I'm looking in through the retinoscope, and I'm looking at the reflex that's coming back out, and then I'm putting lenses in front, which I'll neutralize that reflex, and at that point be able to determine what's called the objective refraction. So kind of what what does it take to neutralize the reflex coming from the eye? And that would be a starting point for the refract of your prescription.
Okay, gotcha. So is it shining a light in, or what are you looking at?
So the auto or my retinoscope?
Either.
Yes, it's shining a light in.
Okay.
Yeah. And so it's looking at the light that bounces off the eye and how it's coming back out again.
So is the eye kind of like a mirror in some ways? Or?
It is.
Okay.
It is.
Yeah. I think of it as a lens, but
so if you get a sense of this, if you take a photo of someone and you see the red reflex, if you don't have red eye reduction on, that is the light that is hitting their retina and bouncing back out at you.
I see. Yeah.
So a retinoscope will utilize that to where we can determine prescription. So this is what we do, say, on a 6-month-old. Who's not going to be able to tell us
say one
or two.
Yeah.
Exactly. Or, a nonverbal patient or things like that.
So there are still ways, these are ways that help you with
that. So that gives us an objective measurement. It's not 100% accurate because you can actually adjust what your prescription is by sort of over-focusing using the lens inside your eye. So So you might notice that image kind of goes blurry.
Yep.
And then it comes clear, and it's attempting to have you relax what's called your accommodation, your ability to focus. There.
Oh, that's what it's doing to me.
Yeah, so that you kind of see it kind of going in and out. It's relaxing, trying to relax the muscle inside your eye. Then it gives a reading and then submits it to us, which is what I'll probably utilize that as my starting point when I go on to further refine that prescription.
Right. Yep.
So that's the auto refractor.
Yep.
Then every patient seems to know, well, depends on which clinic you're in, but have you ever had the puff of air test? Do you know what I'm talking about?
Yeah, I get that one.
Yes. For a while, we had a cartoon up in our office, in our lunchroom, where there was a picture of a dungeon and a torture chamber, and there are people, on the rack strapped to the wall. And one individual saying to the other one, well, at least they don't have the puff of air instrument here. That's how some patients feel about it. Quite honestly, it's startling, but it's not painful.
Right, yeah.
What that test, that's called a non-contact tonometer.
Okay.
And what it is doing, it is blowing a puff of air against your cornea.
Okay.
And there is a camera in there that is looking to see how much it is able to indent your cornea.
Okay.
Wow. And based on how much it's indenting your cornea, will give an estimation of what the pressure is inside your eye.
Okay.
So there are ways you can do it with, this is non-contact, so it's blowing air. There are ways where I do that. I can do the exact same measurement in office where I will put anesthetic in the eye. I will use an instrument which actually manually pushes against the cornea. And again, we're seeing how much it can indent and gives me a reading of the pressure. And we'll get to why that's important, what the pressure, why that's important. The reason why we use a puff of air is because we don't have to use anesthetic there.
Right.
And it's it's a quick, and it's fairly accurate actually, screening test of the eye pressure.
Okay. Is that a more recent thing? Or I mean, I remember when I started having to do that.
So we don't do it routinely on children.
Okay. Maybe that's why.
Because we're screening for glaucoma. And while there can be congenital glaucoma, for most children, there's really no indication for that test to be done. So in our office, I think we start doing it at around age 14, 15, something like that.
Yeah.
So that's measuring the pressure inside the eye. That same instrument will often measure the thickness of the cornea as well, or what's called pachymetry. And the reason why that's important is because when it blows against your cornea to measure the thickness, to measure the pressure inside the eye, it's making an assumption about how thick your cornea is. So if you have a whopping thick cornea, it's not going to be able to indent your cornea very much, and it's going to give you a higher reading than it should.
Than what the pressure actually
is. So this is something that came out around the time of my graduation, or just a little bit before, was the importance of measuring corneal thickness. We know the average is about 555 microns, and before that time, people were being probably treated because they had high eye pressures, when in fact, they just had a whopping thick cornea. So this is just an example of where things we continue to learn and change the ways. So now it's become best practice to measure the cornea and know, is the number that we're measuring in that puff of air test actually accurate, or do we have to add or subtract to it based on the corneal thickness?
Did you say that it's the same instrument that measures that?
In our office, it is.
Oh, okay, neat.
So you might not even know that measurement's being taken. It takes it automatically.
Okay.
Yeah. So that's the puff of air test. In our office, we will also do a screening visual field test, where this is you're sitting in an instrument, and it's going to present one eye at a time, little squiggle lines where you click a button whenever you see one of these. Not every practice will have one of these.
Okay.
And what it's doing is basically mapping out your visual field to determine whether there's any areas where you're missing that.
Okay.
Right? So again, a basic screening test for monitoring visual field function. And then finally, the other test that we do in that front room in our office is we take an image of the back of the eye.
Yes.
Whether it's a retinal photo or whether it's newer technology yet that goes beyond just a photo, where it takes a laser scan of the back of the eye as well, where we not just see the photo of the back of the eye, but now we can actually see all the layers to the retina as well, down to where you can see the integrity of the photoreceptors, the rods and cones there at the back, which is, 15 years ago would have just been, no way, you can't.
Wow.
Or if you did do it, it was, like I said, just the retinal specialist. So now we're able to do that on any patient that needs it.
Yeah.
And so we do that imaging also in that pre-testing there.
Okay. Is that so? You said you do it on everyone, or not necessarily?
So we in our office we take retinal photos on all patients under 40, from 20 to 40, and then we'll also do the OCT scan on patients older than that as well, or at least give them the option for that.
And that's
imaging.
the laser.
Correct.
Image,
yeah, it's called OCT is the short form for it. Mm-hmm.
Yeah, very good.
So that's the pre-testing that gets done. So I'm not really involved in that at all. At that point, then the patient is transitioned to one of our clinical lanes, we call them.
Okay.
And that's where I work out of. And so that's my first encounter with the patient. They'll usually be using our electronic medical records. All that information will be uploaded to me, so I have that when I sit down in front of the patient. And so then that's really when the eye exam begins, eye exam proper. So in our office, we do quite a bit of pre-testing, so I have some patients that come in and they think they're pretty much done with their eye exam, and I'm like, well, no, actually, we're just getting ready to start here. So then case history is a significant part of an eye exam, where we're really trying to uncover what the patient has experienced, any concerns that they have been having. And
is this just focused on eyes, or are you asking about any
certainly eye, but then I'm also going to talk about their general health. What medications are they on? What are any new diagnoses, things like that, which could have an impact on the eye then. So that's where one of the skills that really is important in I think any healthcare field, but is listening, being able to listen and not when you hear something, start thinking, oh, I got this figured out already, but actually listen for the complete story from the patient. So getting a thorough history from the patient. And, a lot of these patients I've been seeing for, let's say 12 years. So it's often, what's changed since last time. But a new patient will take a much longer time. And then we move into checking visual acuity, which is where we determine how well that patient's seeing. Do they see 20/20? So that's the 20/20. Which is sort of an archaic nomenclature, but anyway, it's still what we use. And
what does it actually mean, or is there?
So it's a standard that was created where 20/20 is considered normal vision. All right, someone just decided that's what we're gonna call it, And the 20 stands for 20 feet.
Okay.
Okay.
A distance.
So it's based on distance. So if someone has 20/40 or let's go 20/50 vision, which is the threshold for driving in Ontario.
Okay.
So you need 20/50 vision. That means that what you can see at, let's say you have 20/20 vision.
Okay.
And I have 20/50 vision. What you can see at 50 feet, I have to stand at 20 feet to see the same thing. It's backwards.
So what?
So 20/50 is poor vision. So I have the poor vision here.
So if me with normal vision,
you can stand at 50 feet,
and I would see the same thing that you're seeing
at 20 feet.
Okay, gotcha. Yeah.
It's an inverse relationship, and there are better ways to describe visual acuity, but that's what's been standard, and so that's what we use.
So are there people that have better than 20/20 vision?
So you can have 20/15 vision.
Okay.
I mean, you probably actually do have 20/15. We don't necessarily. Well, I actually do record it, but yeah, it's a line better than 20/20.
Okay.
And so yeah, that's for a young, healthy individual. I would hope that they can see better than 20/20.
Okay. Gotcha.
So it's, even though like back in the day, that was, whether it was the charts that they were using, so maybe not as crisp lines. A lot of our charts are now electronic.
Yeah.
So there are probably reasons why that was settled as normal or perfect vision back in the day, 20/20.
Yeah.
When in reality, we hope to have patients seeing better than 20/20.
Gotcha. Yeah. No, it's interesting to kind of hear some of the history of where those terms came from, and then realizing that maybe they're not.
Yeah.
They don't mean that much anymore, even though they're still used to define things.
What's interesting is that we really should be metric, right? So we're still talking feet. So at the school, they would say your vision's 6'6". So 6 meters. It's in meters. There are your vision 6'12", things like that.
Yeah, gotcha.
But I guess the nomenclature for visual acuity is still in feet.
Okay.
So yeah, you'll see both depending.
Yeah. So how do you actually test for that?
So simply by covering an eye.
Yeah.
And then showing different sizes of letters, which have been calibrated to the length of the
so it's kind of a
room.
set standard that you're going by to come up with.
So that's where the big E is. Back when we had paper charts, it was sort of a pyramid,
right?
Where the largest letters to the top, and then they get smaller as you move down. Where now it's all electronic, or our charts are, and so I can randomize the letters and can mix things up for
because would you have had people memorizing the chart and just rhyming it off, or not?
You will see that even now. So I'll often have patients cover one eye, read the chart, and then switch to the other eye. I'll usually have them read it backwards, just sort of the rhythm of reading one line might kind of. But if I get a sense that they may have that memorized, I have a random switch. I just switch it up. And the pain with that is that I have to turn around and look at the chart myself then at that point in time. Are they getting it right? Because I have the chart memorized, the standard chart.
Oh, I see.
So I can just listen to it. So that's visual acuity. One thing that needs to be said here is visual acuity is important, but one of the big misconceptions in eye care is that if you have good visual acuity, it means that you're free of eye disease.
Oh.
And that's not true.
Okay.
There are, should I say most or many eye diseases that are silent, as in you may be losing vision, but your central vision is excellent still.
Okay.
So glaucoma, for instance, is one that steals your peripheral vision, maintaining central vision until the last stages of the disease.
I see.
So you may have 20/20 vision, but may actually be legally blind because your visual field is so small where you can't drive, but you still see 20/20. So
I see. Okay.
that's a common misconception of people where I don't need an eye exam because I can see better than my friends can, for instance. Well, that's not the end of the story. When you can see 20/20.
So that's another reason to get an eye exam regularly.
Correct.
Even if you
think your vision is excellent. Yeah, exactly. But it gives us an idea of refractive error. So is this patient blurry? Do they need some corrective device? And then when we do put correction in place and their vision is still blurred, well, then we're going to have to dig deeper. Is there some disease process that's going on?
Okay, yeah.
So after visual acuity, then we'll often move into binocular vision testing. So how did the two eyes work together?
Okay.
And
Yep.
it's something I think many of us take for granted unless things don't work together
I see,
well. Because our brain does not like to see two images,
Right.
double vision. And
Yep.
so it's going to work really hard to fuse the two eyes together. And if for some reason they can't do that, it's really uncomfortable for patients, whether they're seeing double or having to work really hard
Yep.
to fuse. So that'd be routine testing where I'm going to be checking, covering and uncovering the eyes to see how the two eyes are working together for clear,
Yep.
comfortable vision.
And is that something that would patients not normally know that if they're having issues with that, or would
They might
maybe
not be able to identify what's going on.
Oh, I see. It might be just subtly.
Yeah,
problems,
so
yeah.
headaches, for instance,
Oh, yeah.
is a common one.
Yep.
Or, if I'm reading for a long period of time, my eyes get sore. What's
Yeah.
going on there? When we read, our eyes need to converge because our paper is held at a near point, and so our eyes need to converge in. So if someone has a difficulty with turning their eyes together, that's going to cause eye discomfort. They might end up just subtly covering one of their eyes without even knowing it, trying to give the eyes a bit of a break.
Okay.
So this is especially critical in children because for children, normal is what they've lived with all their
Always known,
life,
yeah.
right? And so they are not going to be able to identify even blurry vision because that's normal for them.
Yeah.
They might, at a certain age, they might be comparing with other people, whether they can see. But so that's common with, blurry vision or maybe double. Like maybe just everyone sees double. Maybe
Yeah.
just everyone, when they read the words swim on the page or jump around, things like that. So that's where we really care a lot about children's vision.
Yeah.
Because, what is it? 80% of your learning experience comes through your visual system,
Yeah.
something like that.
Okay. Yeah.
So if a child's struggling to maintain clear, comfortable vision, it's going to impact their learning.
Yeah.
And so that's not something the child's going to come in saying, my eyes aren't working together well.
Yeah.
It's up
Yeah.
to us to uncover that.
No, that makes sense. Yeah.
Yeah. So then after the, there'd be some other tests. Color vision testing might be done at that
Okay.
point as well. And then we move into refraction, which is what probably you remember the most about optometry. Your visit is the one or two.
Oh, yeah.
And
Does everyone do this, or is it just if you're looking for a prescription?
So we check a prescription on everyone.
Okay.
So even if someone comes in with 20/20 vision, they still may actually have a prescription there that
Okay.
needs to be corrected. Maybe they're having to overfocus.
Okay.
And so we want to uncover that, or maybe things could be better than 20/20 vision.
Oh, yeah.
So that's when I'm going to take that numbers from what the autorefractor gave when you looked at that
Yeah.
farm or whatever. Take those numbers. I'm going to put that into my phoropter. So the phoropter is that big binocular, those lenses that you look through.
Yeah.
You can
my
picture.
my optometrist calls it a big pair of glasses. Or
All
something
right,
like that.
there you go. Yeah. So that is basically a apparatus that holds hundreds of lenses.
Okay.
All right, in quarter diopter steps. And so I could do the same thing with a trial lens set where I have individual lenses all
yeah.
set out, and I have that in my office, and I'll use that sometimes. So I might have a patient who can't physically get behind the phoropter.
Oh, okay.
And I can
Yep.
do the same thing with putting what's called a trial lens glasses on there and just swapping out lenses.
Mm-hmm.
So the phoropter allows us to flip between lenses really quickly.
Oh, I see. Yeah.
And be much more efficient than using trial lenses. So essentially, what we're doing is one eye at a time. We will either use our retinoscope to get in a starting point, or we use the autorefractor, and we put that in and we fine tune that.
Okay.
So we show options. So we might put that in, and what we're trying to do is we're trying to get the light to focus on the retina. All right.
Oh, okay. Yeah.
That is where we're trying. So someone like you, you're probably nearsighted. You can't see things far away.
Right.
Is that right?
Yeah.
So your eye is too long, is what's
Okay.
going on there.
Mm-hmm.
And so the light is focused in front of the retina. So what we do is we put a starting lens in there, which gets us pretty close to the retina, we think.
Okay.
And then we're going to show you two options, which is going to be ahead or behind, where we're trying to move that focal point backwards or forwards.
Yep.
And what we're looking for is you leading us in the direction that gets us dead on the retina.
Okay.
And that's where, let's say you said 2, and we were showing you a negative quarter diopter. Well, then we're going to add another one in and see if you still like it. And so we're looking for the place where we can show you 2 options, where we're bracketing and you can't really see the difference. So one of the things that I try to tell patients is the end point is actually where you can't tell the difference. Because some patients think, this is so stressful. I need to know, it has to be 1 or 2.
Yeah, I can't tell the difference. Yeah.
Well, that's when patients say I can't tell the difference, that's actually my point to move on. So that's what we're doing in that process. We're also that's moving the image back and forward, trying to get it landing right on the retina.
Right.
You've probably heard of astigmatism as well.
I have, yeah.
Or as what patients like to say, I have a stigma. It's astigmatism. And it has to do with, usually we talk about it in terms of the shape of the front of the eye.
Okay.
Where the light, instead of focused at a pinpoint at the back on the retina, there's a warpage more in the cornea where the light is spread out when it lands on the retina.
Okay.
And we're trying to get both vertical, horizontal, or the 2 meridians of light focused at the same place.
Okay.
And so that's where we're also introducing lenses that correct for astigmatism in there. Okay. And so that's why there's a lot of 1 and 2s going on, because we're fine-tuning the astigmatism and we're fine-tuning moving the light back or forward onto the retina. Right. And something like astigmatism has what's called a power, so how much astigmatism it is, and it also has an axis between 0 and 180. So we're having to rotate things around and fine-tune it. So that's where 1 or 2, we're having the patient fine-tune it, because with just using our objective measurements, it may actually be those measurements may actually be accurate, but it may not be comfortable to the patients. We're actually there's an art to prescribing, where it's not just where physically, the light lands, but it may actually be the patient may actually want it a little bit in front or behind the retina, things like that. Okay,
so there might be a little...
So that's where we will use objective measurements for young children because they can't give us feedback.
Right.
Or for a nonverbal patient or things like that. But we really want to be able to fine-tune the prescription. Okay. And so what you'll probably see going forward, and there's already some markets out there where you can go to a kiosk and have your eyes checked.
Yeah.
And what that's doing is that's just going to give you objective measurements.
Okay. Yeah.
That may or may not be comfortable vision for you.
Okay.
And so that's where I say it's I don't see it totally replacing anytime soon.
Because there are a lot of steps to getting that.
There is. It's probably one of the parts of the profession that is the most tedious, especially for patients who are indecisive or confused. And sometimes there's just a place where, okay, we're going to work largely off of objective measurements here as opposed to subjective. But we really do count on patients giving us reliable input there. But at the same time, it's not something you have to get stressed about that, I'm going to walk away with some Coke bottle glasses here. Things like that.
Or just the totally wrong ones.
I was zoned out in that exam. I'm just going to be blurred for the rest of, till my next exam. Yeah, we have lots of ways to check and double check.
And that's probably, so I've wondered if like you ever get children or anything like that come in trying to pretend that they have bad vision so that they can get glasses like their friends. But that gives you an idea because of the objective measurements and that kind of thing.
They'll still try. Okay. They'll still try. They'll do their best. Yeah. It's called malingering, when patients will intentionally try to make up results so that they can get a certain outcome. And, sort of those 7 to 12-year-old young girls especially are prone to it. Their friend just got glasses at school. And that's a frustrating, if you're talking about things that I dislike about my work, it's when I'm having a really busy day. I'm probably running behind. I have patients waiting in the waiting area, and I have a a young individual who comes in, and I'm thinking, okay, this is just going to be a quick routine checkup.
Should be a good healthy patient.
Yeah, and let's even say last year's appointment was routine, and they were seeing 20/20, and this year they come in and they report they can't see very well. And I asked them, parent, how long have you been hearing this? Well, just sort of since we booked this eye exam, or since the child's known about this eye exam. All right, so we get to check their visual acuity, and they don't read very far down the chart, let's say. And you look at the objective measurements that are coming from the autorefractor, and it doesn't look like there's much prescription here at all to deal with. That's really frustrating because I can't just mark that off and saying, okay, this child's malingering. Okay. I need to actually prove that they truly are not blurred, or that they truly can see. And for some children, they're just really persistent in trying to fake results. Okay. So I have to do everything I can to break down their sense of what's going on in the exam to determine till I actually can get them seeing 20/20. So I try to use different tricks where I actually can prove to myself that, actually that child can see 20/20.
Okay. So is it something you're trying to just make sure for yourself, or is it something you're trying to be able to show other parents?
Well, it's mostly for myself because I need to know whether that child can see or not. Okay. Yeah. And I don't want that child where I just mark it off as though they were faking results when actually they had a serious problem going on. Yeah. So I need to know that they can see. But that all takes time, and that's where I'm saying that's frustrating when you're running behind, and all of a sudden you have to go through all these extra steps. Sometimes it's as simple as putting on, okay, let's try this pair of glasses, and you put in some Plano lenses, so no prescription, and all of a sudden, I can see now. Yeah. Because they have glasses on. Or one of the things, if I have any sense that a child's going to be malingering, and I can often read just in case history whether they're going to, based on how they're describing their blurred vision. Like I said, most children who actually need glasses don't come in saying that they need glasses or their vision's blurred. They come in saying, well, I think my vision's okay. And then I find out that no, actually things are blurry. So if a child's coming in saying, I can't see, one of my first questions is going to be, did any of your friends just recently get glasses? And that's, I think my friend Amy just got glasses. So then what I'll often do is I'll show them an impossibly small letter to see on the chart.
Okay, yeah.
Like 2010, which no one can see that. Can you read that letter? No. So I show them a next bigger letter. So I'm just isolating certain letters. Can you see the 2015? No, that's still too small. Okay, I'm going to show you a really big letter here now. And I show them the 2020 letter. Oh, okay, I can see E. And they think that they've moved up the chart enough to... So that's one of the little strategies that can be used. So children do try to, but we have enough ways that there really should not be any way that a child can get glasses when they really don't need them.
It just might take longer than what you're planning for an exam.
Exactly right.
Is it more than one a year that you would?
Oh yes.
Okay.
So Oh yes. This is something that probably happens on a weekly basis.
I see. Wow, I would not have guessed it was that often.
Yeah. Some children will be pretty upfront saying, or you'll be able to break them down really quickly. Like initially, they might not read very far down, but then you push them and you get down, get them down. But some children are just really resistant, and one of the steps I'm going to take then is, okay, we're going to have to put drops in your eyes to basically take away your ability to focus, and then retake some of those auto measurements, which gives you an even more accurate measurement.
Oh, I see.
When you basically paralyze their ability to focus temporarily. And most times when you start talking about drops with children, that's at the point when you start seeing their vision improve. Okay. If you know what I'm saying. If they get a sense of, okay, things are getting serious here now, I'm going to stop faking it now. But it's something we deal with. Malingering is the term.
Yeah, fascinating. No, I was thinking that maybe that is something that's out of the ordinary that you see. But
a lot of young children. I mean, I think back to myself. I wanted glasses when I was young. I thought, boy, reading in bed without the light on is going to do it. Well, there's no science behind that. It's not a great thing to do just for visual comfort, but it's
It's not going to change your prescription.
Right.
Yeah.
Right.
Yeah.
So it's very, very common for children to want to have glasses.
Okay.
Yeah.
Yeah.
And then by the time they've had it for a year or two, then they decide they don't want glasses anymore.
Well, you could get just clear lenses.
And
too,
some
right?
do, you know.
Okay,
Now, I'll have some patients that will get that and order them up, and yeah.
Yeah. Then
But
they
that
can figure it
fades
out
pretty
for
quickly as
themselves,
well.
Uh-huh.
So after, so we've then determined the refraction. So that's going to help me determine glasses prescription as well as contact lens prescription then as well. Then that's really where we then move into assessing ocular health. So looking at the health of the eyes. And depending on what age you're at or what risk factors you are at, we may or may not put drops in your eyes to dilate your pupils. So that temporarily opens your pupils to allow a more broad view, thorough view of the back of the eye.
Is that more what they'd be like if you're in a dark room for a while?
Correct.
Yeah.
Yeah.
Okay.
So the thing is that we're going to be shining bright lights in your eyes, and so your pupils are going to be constricting.
Right.
And so what happens is, and maybe you notice this with individuals, but so infants have really small pupils. So you might have noticed with Seth at birth, his pupils are really small. By this age, his pupils are going to be larger.
Okay.
And so by 2, 3, I mean, they got these huge pupils.
Okay.
And then as we move through life, our pupils get smaller and smaller.
Okay.
To the place when you're getting up into the 40s and certainly 50s, it's really going to be tough to see the peripheral retina without putting drops in the eyes.
Oh, okay.
So that's where at your age, you may not have drops routinely used on your eyes to dilate your pupils.
Twice, yeah.
But as you move on, and especially if you have high prescription, you're at a higher risk of having retinal problems.
Okay.
So we're going to be putting drops in on younger individuals who have high prescriptions, things like that. So that's when the drops would go in. Then patients would have to wait for the drops to work, and then we were able to look in. And then when we start looking in the eyes, I just basically go front to the back of the eye. Okay. So I start by looking at the eyelids. Are they healthy? Is there infection? Is there inflammation in the eyelids? Then looking at the tear quality. So tears are critical for comfortable, clear vision.
Okay.
So I'm looking at the tear quality. I'm going to look at the cornea. Then is there scarring? Is there dryness on the cornea? Is there a variety of diseases we're screening for when we're looking at the cornea? Moving back then, we're looking into the anterior chamber. So right behind the cornea is fluid, and we're looking to see is there inflammation in there, which would be called a uveitis if someone has inflammation. Most times they're going to be presenting with a red, painful eye if that's the case. Okay. But some individuals can have such low-grade inflammation that they don't even know it, and sometimes we're the first to identify it and then have to figure out where that inflammation is coming. The eye is great for picking up issues from the rest of the body. Okay. So you may have inflammation elsewhere in the body, and it may actually present first in the eye. Okay. Where when we see it, then we have to ask the question, where's this coming from? And may have to dig deeper for that. Okay. We're looking, a variety of things there. We're looking at the drain. So that fluid that I talked about, that fluid is constantly being created and drained from the eyes. And if there's a rise in the pressure in the eyes, so basically a plumbing problem where there's more fluid being created than drained, that is a concern because that can damage the eyes, called glaucoma. So we're looking at the drain where the fluid drains out. Is that open? Is the fluid able to drain out of there? Well, we're looking then, as we move back into the eye, we're looking at the internal lens. So the focusing lens in someone under 40, that lens, we want it to be clear. And if it's not clear, it's called a cataract, which you've probably heard of. So when that lens, which is usually age-related, although not always, becomes opacified, it's going to prevent the light from passing through clearly. Yep. And so we're looking for, is there any early developments of cataracts? Is it a place where we need to refer for surgery? We're then looking inside at the back of the eye. We're talking about the vitreous first, which is the gel that basically
Right.
fills up the eye. Where if you have floaters, that's where the floaters are in. So if you look
okay.
at a lot of people have floaters, which if they've been long-standing and aren't changing, they're probably not a concern. If they're new floaters, that is a concern. But that's the gel. So this gel inside the eye is a collagen matrix, and this with age these fibers will break apart and are free floating. And so that's when you look at a blue sky, you might see like these look like little hairs in your vision or little spots in the vision. So we're assessing that. But really what we're after then is to get to the retina. And that's really where seeing happens, and what we're really vigilant about checking the integrity of the retina.
Okay.
So whether that's focused on the optic nerve, which transmits everything you see to your brain, that's where there's a variety of diseases that impact the optic nerve, whether it's glaucoma, whether it's optic neuritis. We're looking at the health of the optic nerve. We're also looking at the rest of the blood vessels. So one thing that's unique about the eye is it's the only place in the body where you can look directly on blood vessels.
Okay.
So when you look at your hand, you might be able to see blood vessels underneath your wrist, but you really can't see what's going on there. You can't see the diameter of the blood vessels.
So you're seeing a lot more when you're looking in the eye.
We're seeing directly on arteries and veins.
Okay.
And so we can look at the diameter of the arteries and veins, and there should be a certain ratio between the artery and vein where the vein is larger. If the vein is much larger and the artery's gotten narrow, that's indicative of high blood pressure.
Oh, okay.
We can actually see if there's blockages in the blood vessels at times. You don't want to see that because that's an impending stroke. If you see
really?
That,
Wow.
Where you see a plaque in the blood vessel, and those are the patients you want to send to, if not emerge, you want to get them to their family doctor for further workup pretty soon.
Yeah, well.
We're looking at the integrity of the blood vessels. Something like diabetes impacts the blood vessels, weakens the blood vessels, and will cause bleeding, little spots of blood in the retina. And so
we actually catch diabetes from looking at the eye? Like
correct.
That's the first they'll know.
Correct. Yeah. So if I see bleeding inside the eye, microhemorrhages, I won't diagnose diabetes right there on the spot.
Okay.
Because there are a variety of things that could cause it, and sometimes there's no cause found for it. But I'm going to be sending a note to the family doctor saying this patient needs blood work here to work them up for diabetes, hypertension, things like that. Yeah. So we're looking at the integrity of the blood vessels, and we're looking at the macula. So you may have heard of the macula before. It's the most sensitive part of the vision of your vision. Okay. So when you look at my face, my face is focused on your macula. Okay. Everything outside of that is your peripheral vision that's falling outside of your macula. Yep. So your macula is very sensitive, and it is critical for clear, comfortable vision for that to be the integrity of the macula to be maintained. Okay. And if there's any distortion, degeneration, so what's called macular degeneration is a leading cause of blindness in the elderly. It's when that most sensitive part of the eye is damaged. Okay. So that's where we're looking at that, looking for macular degeneration or swelling there. And then we're also going to look at the peripheral retina, looking for any holes or tears in the retina, which could predispose someone to a retinal detachment. We're looking for retinal detachments. Okay. Yep. We're looking for, so you know how you have freckles on your arms, or you might have a freckle, things like that. The thing is, you may have freckles in your eye as well. Okay. But so it's concerning when you have them on your arm and they change color, shape, things like that. Well, you can't tell if you have those, A, in your eye, and B, if they're changing. Yeah. And so that's where we're looking for that. So that's where something like photography really becomes useful. So taking those retinal photos of the back of the eye, where we can actually monitor from year to year to see if there's any changes. Right. Yeah. So we're looking for cancer in the eye as well. Yeah. So that's sort of from the front of the eye to the back what we're assessing. So
are you able to see all of these different parts of the eye and study them just from looking into it with a light? Okay. Yeah.
Wow. So this is what I'm doing on a regular basis in an eye
just
exam.
For those couple minutes while Well, my optometrist is shining her
When
light
things are
into the
really
eye.
bright in there,
Yeah.
yeah, that's where, and that's where I say a large part of our job is thankfully looking at healthy individuals.
Yep.
So we're looking at normal retina. And so what really becomes critical is, can we pick out what's abnormal?
Okay,
Then
yeah.
as we're scanning all around the
Yeah.
retina there.
Is this is it something that you've been able to learn and recognize from doing it, or would if I would actually take the time to get that close and shine a bright light into someone's eye, would I be able to pick out things that I've never seen before as well?
Well,
Or-
you probably wouldn't recognize what's normal and what's abnormal.
Well, yeah, but even like would I see the different parts and things like
Oh
that?
yes.
Yeah.
Oh
Yeah,
yes. Yes. I mean, there's if I were to show you retinal photos for sure,
Yeah.
you would be able to see, abnormalities. There is certainly a trained technique of holding the lens in front of the eye and keeping all your optics where you can actually see in. So that's where, sometimes I'd love to just, hey, have a look at this, but it's going to be pretty much impossible to look through my microscope through a lens and into the eye for the untrained person. But that's where photography is fabulous.
Yeah.
To be able to take photos and show it to patients, for instance.
Right.
And even in a teaching center, we had microscopes where the students could be looking in with us and, and observing there as well.
Yeah. Okay. So, nice. Mm-hmm. Yeah. So most of these these scan or tests that you're looking for would be done. You're looking through a lens. You're not just looking.
Correct.
Okay.
So looking through, I didn't explain some of the instruments we'd be using. So the one where you put your chin on the chin rest, and that's called a slit lamp. And so without holding any lenses, we're just, in our oculars, we have magnification built in there. So that's when we're looking at the front of the eye. Okay. But as soon as we move past that internal lens towards the back of the eye, that's when we're going to be holding up a much higher powered lens that we're looking in to see the back of the eye. And then to check the peripheral retina, the way I do it anyway, is I use a head-mounted microscope called binocular indirect ophthalmoscope that I use to look inside. Mm-hmm.
Yeah, very good. So are you done
that's pretty. Then? I mean, at that point, then it enters into counseling then with the patient, where I sit down, and that's a big part of optometry is educating the patients. Patients, thankfully, most patients anyway, care a lot about their eyes.
Right. Yeah.
It's one of the most prized senses we have,
for sure. Yeah.
And so this is I really enjoy this interaction that I can have with patients, where I can educate them on healthy eye health, but also that extends into healthy living as well.
Okay.
Yep. Whether it's healthy eating, our eating impacts our risk for certain diseases.
Right.
Smoking's a big one. So, when I see early signs of macular degeneration, smoking is the leading modifiable risk reduction you can do.
Really?
Yeah.
I see. Wow.
And so when I can have that conversation, they've been told before that they should smoke, but when you alert them that their vision is being threatened by this, all of a sudden that ups their motivation significantly.
Yeah.
So education is big in that, to talk about eye health, but then also visual options. So just because you have a prescription, there are so many different options to talk about. Should we be talking about refractive surgery? Should we be talking about glasses? What type of glasses? Contact lenses, etc. So my goal as an optometrist is to really allow patients to make informed decisions, to present what I feel are their best options, their selection of options, and then give them enough information where they can make an informed decision about what they want to do.
Yeah. So, that makes sense.
And then at that point, that basically conclude. There may be further testing then that I want them to do, which we would have in our office then, further visual field testing or things like that. Maybe if they have a concern, a surgical concern, for instance, I would then be writing a letter to a family doctor or to an ophthalmologist to refer them on for further care.
Yeah. Oh, very good. You talked about some of the diseases and things that that you'll see, and but you also obviously see a lot of healthy eyes too. Do you occasionally come across something that you've never seen before, or have you seen pretty much everything now?
Yeah, so the longer you're in practice, you see less and less of that. So when I first graduated, that happened very regularly.
Okay.
It's like, whoa, I haven't seen this before, and where I'd even be pulling out the textbook or needing to figure out what I'm doing with, and maybe even sending the patient out for getting second opinions from ophthalmologists. So maybe I should just stop right there and just explain some of the differences here. So they're the 3 O's: opticians, optometrists, and ophthalmologists. Opticians fit, maybe even fabricate, but fit and adjust glasses and contact lenses. So that they might be in an optical store. It's a college program, maybe 2-3 year, I forget. Where they take their prescription from an optometrist and they may make glasses. So I can fit and adjust glasses as well. But opticians, that's their scope of practice. Yeah.
So do you have some in the clinic?
We do. Yeah. So they are the ones who will be taking measurements on patients as far as getting the glasses lined up properly, things like that. They'll do our contact lens instructions, getting patients up to speed there. Then there's optometrists. So we're the primary eye care. So if you have an eye care, and whether it's an eye problem or whether it's routine care, you're in this community anyway, you're going to be seeing an optometrist. And then there are ophthalmologists who are medical doctors who have then done, I think it's a 5-year residency above and beyond.
Oh, wow.
It's
so they're not doing the same optometry school that you did?
No.
Oh, okay. They're doing.
So for me to become
school.
an ophthalmologist, I would have to go through medical school.
Okay.
Gotcha. Yeah. So they are physicians who have then gone on for a 5-year residency in eyes.
Okay.
And probably one of the most obvious differentiation between them and optometrists are their surgeons. So I don't do surgery; they do surgery. But they're also secondary level providers, such that if there are concerns that are outside of my scope of practice or that I don't feel comfortable managing, I'm going to refer them on to ophthalmologists.
Like things connected to the rest of the body, that kind of thing? Like, would they have more
Not
knowledge?
so much there.
Oh, okay.
I'll refer them. So if I'm concerned about something brain, I'm going to refer them probably on to a neurologist as opposed to at least a general optometrist. I might refer them to a neuro-ophthalmologist. So,
there's specialties within that as well.
Correct.
Okay,
Yeah.
wow.
So I utilize many different providers there, but ophthalmologists are the ones that we will. There are things that are not in our scope of practice, like certain types of glaucoma, for instance, I cannot treat.
Okay.
I might be able to co-manage with the surgeon, and so it's a back and forth. The patient might see them half the time and me half the time.
Okay.
So ophthalmologists are surgeons, but also are take on the more complex care of patients as well. So that's I'm not sure how we got there, but that I thought we should just clarify the opticians, optometrists, and ophthalmologists.
So
go ahead. I think you were asking about strange
things out of the ordinary.
Yeah. So that's where I would utilize ophthalmologists to get a second opinion.
Right.
Where I don't do that as much anymore, just as I have more experience in practice.
Oh, okay.
I've seen this before, let's say, or I've managed this before. And with some of the new technologies, we have the same technology as what the ophthalmologist has. I can diagnose it as well as they can. Yeah. But there are still times when I look in and I say, I've never seen that before.
Okay.
Thankfully, not too often, but yeah, those cases still present. Yeah.
Okay. Yeah. And that'll be like some rare disease?
Yeah. So this was really strange. About a year ago, I had a 2-year-old in the office. He was just in with his family, with his siblings, and he wasn't booked for an eye exam. And I had a slot right after their family. And so I said, "Has he had his eyes checked before?" And no, he hadn't. And Mom's like, oh, there's no concerns here. He's doing just fine. I said, hey, I'd be happy to slot him in yet. I have time, and
Yeah,
we'll
it
get
doesn't
in.
cost any extra
Right.
in Ontario.
It's
children.
covered. So okay, sure. And so I looked in, did the checkup, and he was seeing fine. But I looked in, and I'm like, wow, there are what are called exudates all around his blood vessels back there, and I'd never seen. It's called Coates disease. I'd never seen that before, and I'm like, I'm pretty sure that this is what this is.
Okay.
And we have some great staff in our office, and they were able to take a photo of it because a 2-year-old's pretty tough to be holding steady while you're looking in the eyes and being confident of the diagnosis. And so I was able to get photos, and then I felt more confident about what we're dealing with and sent him to Sick Kids in Toronto, which he's been seeing since for managing this. And I'm not sure where the outcome will be, but anyway, that was just kind of a totally unexpected diagnosis.
Yeah. And sorry, then, what is is it an eye disease?
It is.
Yeah. Okay.
Yeah. And he'll probably lose vision, at least in one of his eyes.
I see. Wow.
But he'll probably have some laser work to manage that as well. And then just in the last, it was just prior to COVID. I'm looking in and I see another one in it. This is a teenager's eyes of the same thing.
Same thing. Wow.
It's like one in, I don't even know how many 100,000.
Okay.
So to have, maybe it's 1 in 100,000. I forget. But to have two just within a short time with having not seen any before that was strange. So still see unique cases. Not on a daily basis, but on I don't know, every so often. Anyway.
Yeah. Mm-hmm. Yeah, very good. You've talked about several things that you dislike and also some things that you enjoy about your role. You've talked about how you get to interact with people versus your research job that you did there between years in university. But is there something specific you wanted to mention that you enjoy about your
Well, yeah, people job? Is big. And one of the really unique things is the diversity of people. So we're seeing whether it's ages. So my patient might be a 6-month-old and my next patient might be a 90-year-old.
Yeah.
All right. And so ages will fluctuate throughout the day. It's also walks of life. So it may be a lawyer of a high-end firm, and then the next patient, a minute later is a shy old order Mennonite 5-year-old, and so just kind of this whiplash, but at the same time it keeps you the day is not routine. And so I really like that, and just wonderful people. One of the things about optometry that I probably didn't see fully when I went into it, but it's really significant for me, is the ongoing relationships I can have with people. Something like a surgeon, let's say, if I would have become an ophthalmologist and I'd be doing eye surgeries, you might have a few interactions over the time of surgery, but you're probably not going to see that patient again unless there's
hopefully not,
further complications down the road. Where an optometrist, so I've been in for 12 years now, and for some patients, I've seen them every single year for 12 years. I've watched children grow up.
Yeah.
Unfortunately, I also have patients who I don't see again because they've passed on. But just this following patients through life, is and relationship building from year to year. So when we sit down, when I have a patient enter, we'll usually spend a bit of time getting caught up, and that's to build rapport with the patient, but it's also to get a sense of what is visually significant in their life. So do they have certain hobbies that have certain eye requirements? What about their work? Are they sitting in front of a screen for hours at a time? So wanting to get a bit of information about their life. And so I'll often jot some notes in my file about that, and then be will to, that might bridge into a conversation that then next year, hey, you were talking about this last year. And so, that's something that I wasn't really thinking about when I went into optometry. That's just been really significant for me, is that ongoing relationship with patients where we're now, I can look at my day's list of patients that I'm seeing, and good chance I'll have a mental picture of a lot of those patients on the list. Or if not a mental picture, I'll have an eye picture. I'll think more in terms of what are we dealing with here visually, and I may not even be able to have a mental picture of who they are. So that's, or I remember he has just this whopping prescription that, or a challenging prescription.
Okay. Yeah.
So that's something that, that I really like, about my work is the diversity, also the diversity of care. So I haven't talked about emergency care much. Yeah. I've been talking about routine checkups. So we deal with ocular emergencies as well, whether it's eye infections, whether it's someone coming in who was grinding and wasn't wearing his safety glasses and has metal in the eye that I have to remove, whether it's a patient coming in complaining of new onset flashes and floaters where we need to investigate for a retinal detachment, or maybe they've just experienced some sudden vision loss, or things like that. And so those are often fit into my day along with the routines exams, that really gives routine exams as in any job can get routine, where it's or monotonous maybe is what I'm saying, where as long as there's no issues, it's kind of the same thing. Mm-hmm. So there's enough non-routine though that I'm grateful for in my work.
Will you be seeing an emergency appointment once a day, or is it not that often?
More likely to 2 or 3 emergency. Well, maybe 2 emergencies on average is what I see in a given day.
Okay.
Mm-hmm. Yeah. But emergency may mean I've had a red eye for the last 3 weeks that's not going away. Yeah. And I've seen my family doctor and they've been prescribing antibiotics for it and it's still not getting better. Okay. Yep. So it's not a true emergency. What we're talking about, it's a
but they might have come in outside of their annual appointment or something.
Anything like that, unless we've pre-booked them, is going to come in with being called an emergency. Yeah. Some are true emergencies where a chemical burn, for instance, where we need to act quickly, and some, the eye is incredibly sensitive, so patients can come in extreme pain depending on what has just happened. If they've just scratched their eye, for instance, their cornea, or they have something in the eye, that we were going to want to act on those as quickly as possible for the patient's sake.
Do you see a welder's flash ever?
We do. Most welders, they've experienced it before, so they've kind of learned that this is going to self-resolve.
Oh, okay. It's not really something you can do anything for? Or?
There's not. I mean, we'll put anesthetic in their eyes, and that will feel amazing for 20 minutes, and then the pain comes back again. But it's a matter of cold compresses and closing the eyes, lots of lubrication, and thankfully the cornea is really quick on reepithelializing and covering up those pain receptors that are exposed.
Is that a lot of eye injuries that they'll heal on their own, or can you do things?
So
it
depends.
Them as well?
So if it's something like mechanical abrasion, that's going to heal on its own. We will often put a bandage contact lens on there to basically assist in pain reduction, but also just enables better healing as well. But then as soon as you have an abrasion like that, you run the risk of infection. And so then we're going to be seeing secondary infections, things like that, and needing to treat with antibiotics and et cetera. Yeah. So the diversity, in patient base, the long connections that I can have with patients are all things that I enjoy.
Nice, yeah. Are there, you talked about that, it can get a little routine. Is there other things you dislike about the job?
Well, I talked about malingering children. This is something I enjoy and I don't enjoy at the same breath, is grumpy patients. And I'm sitting down with this patient for 30, 40, 50 minutes, and if they're having a rough day, they don't necessarily leave that at the door. Right. And unfortunately they sometimes take it out on staff, which I don't appreciate. But So while I don't enjoy that, at the same time, I enjoy the challenge of changing their
yeah.
outlook on their day, and trying to have them leave my exam room in a different state. So it probably depends on my mood, what energy I have for patients coming in, and I just have to remember I have no idea what's happened right before this eye exam. I have no idea what they've experienced that day, and so I hope I am very compassionate towards them, but I do enjoy the opportunity to change their outlook.
Yeah.
Anyway,
is one of your strategies to bring up a conversation from a year ago? And
that can be. Yeah. Patients, I think all of us like to talk about ourselves.
Oh yeah.
And
sure.
And so that can be, and just trying to focus on. Again, I mentioned eye care is something people care about, and so just talking to them about, something really positive of what I'm seeing here with their vision, or what I'm not seeing, more likely, and helping them to be grateful for, wow, this is amazing how well I'm seeing here.
This is a little bit of an aside, but people we talked about how much vision is probably one of our most important senses, and something that we'll talk about if we're having issues and things like that. So do you find that it's something that people will ask you a lot outside of your practice, like friends, family, that kind of thing?
There are. I mean, there's not, I don't know how many optometrist friends you have, but I'm guessing not too many.
Not many,
right?
No, exactly.
And so, it's probably different than nurses, where you probably have multiple nurses that that you can ask questions about certain medications. So yeah, I do get some questions. A lot of them are, the most common question is, what do you think about laser surgery?
Yeah.
That's just the question to ask an optometrist. Okay. So I don't know if you're going to ask it or not.
Well, I am. Yeah, we'll make sure we get to that one before we're done. But I have a few more questions here, just like on the eye and things like that. I don't know if we'll spend a lot of time there, because you've already talked about some of the different parts of the eye and some of the different diseases that you see and that kind of thing. But maybe just, can you, in a minute or two, just kind of give a description of how the eye works, or a explanation of how those, you talked about some of the different parts, but what's actually happening in order to allow us to see?
Yeah, so I mean, you've probably heard about it being a camera, and that's not a bad analogy, of where it is taking light rays that are coming from an object, that are passing through different refractive materials, so your cornea being your main one, passing through an internal lens with the interest of it landing on a screen, your retina, at the back of the eye, which is then...
So the retina kind of captures it?
It does.
Yeah.
Okay. The rods and the cones there, and which initiates the phototransduction cascade, which is an incredibly complex cascade where it's translated into a neural impulse.
So when you say a really complex cascade, is it a chemical reaction?
Yes, and all of the it's complex. It's it's chemical, and very, it's one of those things where I would have studied it in depth 12 years ago, or 14 years ago, whenever. For me to actually explain it today is impossible. I don't need that information, but
it's basically taking the light and changing it into a signal that the nerve can send to the brain.
To the occipital lobe at the back of the brain.
Yeah.
So that's in essence what is happening in vision, and then there is things that can go wrong in that process, where either the eye is too long, the light's focused in front of the screen or in front of the retina, which is nearsightedness, in which place we need to put a lens in front of the eye to actually, so the rays are converging in front of the retina. So then with a myopic prescription or a nearsighted prescription, we have to put a lens in front that's actually going to diverge the light, so that when it passes through the eye, it reconverges at the right spot. So that's the idea of a myopic lens. In a hyperopic lens, so someone who's farsighted, then the light is focused, as it were, behind the eye, and so the eye is too short, and so then we need to put a plus powered lens in front that's going to converge the light more to aid the eye in getting the light converged on the retina.
Okay.
So
that kind of works along with it.
Yeah. Then. So whether we're talking glasses, whether we're talking contact lenses, it's the same idea. Whether we're talking refractive surgery, it's the changing the shape of the front of the eye to diverge the light or converge the light, as the case may be.
And refractive surgery, is that the same, like what laser surgery would be?
Yeah. Same. And one other thing that you're probably not thinking about at this point, but you will when you cross 46 or 47 is the ability to focus. So what we've been talking about here is a largely static visual system where the light's coming in and just passing through without the eye modifying that.
Right.
Changing the shape at all to modify that convergence. And that's where the lens inside the eye can change shape to focus the eye, focus the light. And that's what happens as we age. The ability to focus that lens deteriorates, which then usually starts having issues where people are trying to focus at near.
Right, like reading or something, or your phone or something like that.
Correct. Yeah. And the lights, they just can't flex that lens as they used to, and are then going to need further aid for reading up close.
Is it muscles that are?
So it's a combination of its muscles and also the lens that changes shape mechanically.
Right.
Gets stiffer with age.
Oh, okay. So it's just harder to do it.
Yeah, it is. It's called presbyopia.
Yeah. So is there anything you can do to stop that? Or you said 46, 47. Is that the most typical age? Or?
That's when, if someone doesn't have any corrective, let's say if they're nearsighted, that age might be pushed out a little bit longer because they're naturally nearsighted, so they can see up close longer.
Oh, okay.
All right. But yeah, that's sort of the age where at 40 centimeters, where most of us read 40 to 50 centimeters, that's when we're going to start having to push things back a little bit to see things clearly. So that's a big part of my work is managing presbyopia. So a lot of people coming in who've maybe had perfect vision all their life, maybe didn't have an eye exam and thankfully didn't have eye disease, but they're hitting those upper 40s and all of a sudden are coming in saying, my arm's not long enough. I can't see this print anymore, and needing to think through options for them.
Okay. Yeah. So that's one thing. So will a prescription actually change throughout a person's life as well?
Yeah. So I mean, the eye is growing. So as a child,
right?
All right. So the eye, as the child develops, the eye is going to grow, and so if there's a mismatch there, they're going to develop a prescription.
Okay.
But we're also talking about a very finely tuned system that it doesn't take as we go through life. The eye is not static, and so things can change, and so we'll often see an increase in prescription as time goes on. So so someone doesn't often have the exact same prescription for years on end.
Okay. Yeah. No, that makes sense. Kind of as the last section here, I like to see if there's any advice, and maybe we'll start with this. You said you often get asked about laser eye surgery.
Sure.
So is it a good thing to do? Is it successful?
So my standard answer for a stranger on the street is it all depends. Talk to your optometrist about it.
Yeah.
Because it's unique to every person.
So not everyone's a candidate for it? Okay.
Correct. It should not be done on every person, depending on there are contraindications when it should not happen. And so it's going to depend on a variety of factors. The next thing I might say is that I had it done personally. Mm-hmm. And so that answers probably the question of success and safety. Whether
you trusted it enough to
do
it.
Yeah. But I knew I was a candidate for the surgery.
Okay.
So we're talking things about, I talked about your corneal thickness, pachymetry there at the beginning. What they do in laser surgery is they actually remove some of the cornea. So they thin it. So if you have a thin cornea and they're going and thinning it further, that can predispose you to having an unstable cornea. So that'd be one indication, but certain prescriptions might be out of range where they have to remove too much tissue for it to be successful, or
But that can all be measured like ahead of time
correct.
and known. Yeah. Okay.
Exactly. So I do a lot of counseling for patients whether I feel they're a candidate for surgery.
Yep.
And I try to let patients know whether, if they are a candidate, I want to let them know that that's an option. So that's one of the informed choices that I try to give patients to let them know. And then their next step is to go to the surgical center and then have a further consultation there.
Okay. Yeah. So are there complications with it sometimes with a perfectly healthy person, or is that extremely rare?
It's very rare.
Okay.
It's very rare. Yeah. Personally, managing a dozen years, I haven't had any significant complications.
Nice.
Yeah. Biggest regret patients have with laser surgery is that they didn't do it sooner in life.
Yeah.
That's especially those who wait into their 40s or beyond. Why didn't I do this sooner?
Yeah. So. Has it been doing? How long has it been being done now?
That's a good question.
Years?
Probably since the 70s is probably where it was sort of first being done, but more routinely since the 90s.
So will it last 30, 40, 50 years?
The idea would be is that to lifetime, I mean, a lot of laser centers will give a lifetime guarantee with it, where if things do change down the road, they'll come back and redo the surgery.
Okay. Well, you still need reading glasses when you're
correct
in your 40s?
at this point in time, but that's where technologies continue to change, and where even now with certain types of surgeries where they're doing this is sort of a different type of refractive surgery where they're doing what's called a refractive lens exchange, where they're actually changing the lens inside the eye and putting a bifocal type lens inside there, which allows someone who's 50 to be glasses free. So that's something that is where I'm seeing a lot of more interest than wasn't even really an option for majority of patients even 10 years ago, where I'm offering that to a lot of patients now.
Wow.
Yeah.
Is that so I came across this term implantable contact lens. Is that being used correctly?
It's a bit of a misnomer, but I know what you're talking about.
Okay.
It's quite rare.
Okay.
It's for individuals who have such a high prescription that they're not eligible for laser surgery.
Okay.
So they have to have too much tissue removed to capture the full prescription. And they're too young, usually, to replace the lens inside the eye. So someone who's under 45, they still have the ability to focus, and no implant is going to mimic our natural ability to focus.
See. So it's not something you'd want to do.
So you don't want to go in and replace that lens, because as soon as you replace that internal lens, you can adjust the power of that lens and allow someone to be glasses free. So that's where a lot of patients after cataract surgery may actually be glasses free. But you don't want to mess with that lens while they still have the ability to focus. Yeah. So what they're doing is basically putting another lens directly in front of that lens.
Okay. Yeah.
So it's not actually a contact lens, but it's
like glasses inside the eye.
Yeah, that idea.
Yeah.
Yeah, right in front of the lens, which is actually removable then as well. So it's not not something that could not be removed if need be. And when someone were to actually go ahead and have cataract surgery, they'd probably take out both that lens and the natural lens and replace it with one lens then at that point in time. So there's different technologies and techniques for patients that are not in the LASIK parameters.
Okay.
But those aren't routinely done in this area here. That's going to be done in Toronto, most likely.
Okay. Yeah, so it's a rare thing.
It is. Yeah. Yeah. So for instance, that implantable contact lens, I don't think I've ever seen a patient with that.
Okay.
All right. So
it's very rare then.
That's that uncommon. Yeah.
Yeah. Very good. I guess for the last few minutes here, I'll ask you for advice that you have for regular health, or taking care of your eyes, making sure that your eyes are healthy, and just anything else you want to say as advice to finish it off.
Sure. Yeah, I think just eye care. I mean, eye health is really important, and I care about that. Obviously, I'm probably biased here because this is my this is what I do. But it's just really difficult when I have patients who have lost preventable vision.
Right.
If you know what I'm saying.
Yeah.
I'll give you a story here. few years back, Friday afternoon. These things usually happen Friday afternoon. A 30-some-year-old gentleman comes in, and it's just been a long time since he's had his eyes examined. He's not really concerned. And in routine testing, well, actually, now that you know some of these terms, when he was having his pressures checked at the front,
Yep.
it gave an error message on there, which usually means his pressures are out of range.
Okay.
And so that's when I have to pull out and actually manually measure them
Okay.
there. And his pressures were way out of normal range.
Wow.
And which is going to cause damage inside the eyes. And it's painless at this point. When it reaches
Okay.
a certain pressure, it can cause pain, but at the pressure it was at, he wasn't having any discomfort. And so then I look in at his nerves, and they don't look healthy.
Okay.
And I run a visual field on him, and he's already lost a good bit of his visual field, which is permanent vision
Wow.
loss.
Okay.
And this guy's young,
Yeah.
and he's going to have to deal with glaucoma care. I mean, we don't like to see glaucoma in young patients because there's a lot of life to live, and there's no cure for glaucoma. We can slow it down.
Okay. Yeah.
So someone like that is going to, we've already lost a lot of ground
Yeah.
on someone like that. So that's where, something like teeth, I'm not a dentist, so I'm probably misspeaking here, but my thought is you can always get dentures,
Right.
if for some, if you don't pursue dental care, but you don't have replacement eyes.
Right. Yeah.
Right.
You can correct vision, but you can't get that vision if it's not there.
If it's not there. So just not to be fooled by 20/20 vision.
Right.
This gentleman, for instance, would have had 20/20 vision, but there were other things going on.
So if
as
you would
well.
have, if you would have gotten it checked 15 years earlier,
Right.
would you have been able to slow down some of
Absolutely,
that?
he would have been on drops or surgery to
Okay, yeah.
lower the pressure inside the eye,
Right.
and give him he still would have had glaucoma. It would have not. I mean, what we're aiming for is to not have vision loss,
Yeah.
functional vision loss in life. So yeah, just a plug-in for regular eye care with an optometrist, especially for children. I mean, for everyone, but not to neglect children. And in Ontario, eye care is covered for children under 20.
Right.
And so there's not a good reason, I don't know of a good reason not to have that built in as a regular rhythm for a family.
So we should already be getting our 1-year-old.
So we start examining at 6 months
Okay.
of age. Quite honestly, if your family doctor, if your midwife, obstetrician are doing their work, they should catch most of those critical things
Okay.
at birth or soon after. So certainly by age 2 to 3
Okay.
is a good time to get their child in there and for us to examine them. So yeah, child eye care, really, really important. And maybe just eye protection as well. I remove a lot of steel from especially guys' eyes.
So just a pair of safety glasses?
Yeah, it's usually I just have a quick grinding project here that's not worth reaching for my safety glasses.
Yeah.
And we all take risks in life, but I just see a lot of steel in eyes that, while it can be removed, depending on its location in the cornea, may cause vision reduction.
Okay. Like you will see
scarring.
permanent damage.
Yeah, scarring is what
Okay.
we see.
Yeah.
And so if it's at the visual axis, it's can cause problems there.
Okay.
So just eye safety
Yeah.
is something else to care about.
Yeah. And I'm sure like the body is connected in so many ways that just healthy living in general, like you said, not smoking and
Get those colorful vegetables in your diet too.
Yeah.
Go to Martin's. Yeah. Eat an apple. Your colorful peppers and kale and those dark green leafy vegetables are all good for your retina.
Yeah.
Mm-hmm.
Are carrots good for your eyes?
So they are, but nothing like people would think they are.
Okay, there's nothing special about them.
I mean, they have carotenoids in them.
Okay.
Night vision, maybe they can maybe boost a little bit, but you'd have to eat a lot of carrots. You're probably going to be orange before it's going to make much difference there.
Do you know where that came from? Like where that idea came from?
I believe it actually came out of the Army, when they actually found that if soldiers had improved night vision if they ate a lot of carrots.
Okay.
I think, I'm
But
a little sketchy on it.
How would that have been measurable there? Or how would they notice the difference?
Well, anecdotal.
Yeah,
probably.
Well, that's
just
true, yeah. That's a lot of things are.
They are.
Yeah.
So yeah, I don't be buying up the carrots just so that trying to prevent yourself having to wear glasses.
Yeah.
Mm-hmm.
All right. Well, I always enjoy learning from you about the eye and the different ways that we can take care of them and ways that you examine them and things like that. So thanks a lot for sharing and teaching.
You're welcome.
Here.
Pleasure.
Thank you, everyone, for listening, and thank you, Richard, for sharing your knowledge with us. I learned a lot from this conversation about how the eyes work and what's behind the different procedures and tests that an optometrist is doing. So it was really interesting to learn those things. I also thought it was a really good reminder to get my eyes regularly checked, even if I feel like my vision hasn't changed or that I'm seeing just fine, because there could be things going on there that I'm not realizing. So that it's a really good idea to get into the optometrist for a regular checkup. Eyesight is definitely a sense that I value and is worth keeping. So thank you, Richard, for sharing those things with us. As I mentioned last week, I'm planning to bring my brother, the graphic designer, my podcast partner, but not famous singer, Ricky Martin, back to the show for an audience question segment. We will answer any audience questions or share feedback that we receive, and it can be about basically anything. About the podcast is what we had in mind, but yeah, go ahead and ask us anything. Planning to do that recording on September 29th, so anytime before that, you can send me an email at contact@everydayexpertise.ca. Use the form on the website, which is everydayexpertise.ca, or you can send me a message on social media. I've really been enjoying getting messages from some of you, and I'm hoping to hear from a few more. That's all for now. Join me again next week to learn from the expertise of everyday people.